All right, good afternoon, everybody. Welcome to the next in the Region 5 trainings. Today we'll be talking about demystifying the differential diagnosis process. I am Chiquita Merrill, the SKIP supervisor. SKIP stands for School Intervention Program here with Western Tidewater. My credentials are LPC and I'm also an ACS. So we'll be talking today a little bit about the differential diagnosis process. We'll also be talking about some other additional things, including some of the new additions to the DSM-5 and also some steps to creating your own decision tree when getting to the process of your differential diagnosis. All right, so our objectives today are going to be to build on your existing knowledge of assessment and diagnosis. So in this training, I am assuming that you all have some working knowledge on how to do an assessment, how to create a diagnosis. So we're building off of that skill set. And some of this you may know, and some of it you might not know. This might be a complete refresher for you. This might be completely new. Not sure. Just roll with us. We're going to talk about the DSM-5 method of differential diagnosis. I do want to note that there are other methods of differential diagnosis, but today we're just going to be focused on that step process that I think it's 5 steps. No, excuse me, it's 6 steps in the process of the DSM differential diagnosis. Hopefully we will enhance some abilities in your gathering information portion of your assessment. I hope to create a framework of arriving at the most accurate diagnosis during assessment. And I do say the most accurate because, of course, sometimes things don't always come out during the assessment process. So you might not get the exact right diagnosis, but we're trying to get to at least the most accurate that we can get to within the intake process. For the most of us, an intake process is about 2 hours. So it is just a snapshot. So we work with the information that we gather during that time. Discuss considerations for, of course, medical conditions, culture, age, presentation, and also some ethical considerations when we're talking about provisional diagnosis. So what is differential diagnosis? So the definition is actually, when you say differential diagnosis, I'm sure it kind of comes off as like the diagnosis differences that you can come up with. Like, oh, is it generalized anxiety disorder? Is it separation anxiety disorder? Actually, the differential diagnosis is actually the process of ruling out other diagnoses. So it sounds like it's a noun, but it's actually a verb. It's actually something you are actively doing during your assessment. And why is it important? So off top, for me, it's important because at the end of the day, this is a label that you're giving to this client and it drives your treatment. Obviously, you're not going to treat a person that is diagnosed with major depressive disorder the same that you would treat a person that has schizophrenia. There might be some similarities, but there's certainly going to be a lot of difference there. And so arriving at the right or most accurate diagnosis is going to be very important. Are there other considerations that you might think of when talking about differential diagnosis, why that might be important? Anybody? Why would differential diagnosis be important?
It can be important because sometimes more than one diagnosis, some of them can be comorbid with something else. So you want to determine what is the most prevalent at times, or what symptomology or diagnostic criteria best fit that particular individual to rule out something else. And to also see if the two are comorbid for this individual as well.
Comorbidity is definitely a huge part of differential diagnosis, absolutely. Anything else that comes up for you guys? Okay. All right, we'll keep pushing. All right, so when speaking about the 6 steps to differential diagnosis that is outlined in your DSM-5, it starts with ruling out a few things. We first want to rule out malingering and factitious disorder. We'll also rule out any substance etiology or substance use or substance abuse. We'll also want to rule out disorders due to a general medical condition. Once we've ruled out those things, then we're going to work on determining the specific primary disorder. And we'll start to differentiate between adjustment disorders and residual other or unspecified categories. And lastly, we will establish a boundary when there is no mental disorder. So these 6 steps are outlined in your DSM. They're outlined by the DSM writers, but it's actually utilized in a lot of different areas. So not just with mental health, also doctors, other mental health professionals, psychologists, school counselors, social workers, everybody should be using some version of this differential diagnosis modality. Another thing to note about this is that it's not linear. It's not a step 1, step 2, step 3 kind of situation. All of these things are actually going to be working together throughout your assessment. We're going to talk about them in a space of, step 1, step 2, step 3. But just know that when you're actually putting this to practice, it's going to be something that you're doing throughout time. Alrighty, so our first step that's outlined in DSM is malingering versus factitious disorder. So one major thing when it comes to diagnosing is that we are going off of a good faith collaboration between ourselves and the client. And that is to say that we are assuming that when our client comes to us, they are telling us the truth. They're being honest about what they are experiencing, what their symptoms are. We have to assume that because that's the only way to kind of gather that information. In that same process, however, you're also going to be doing a little bit of assessing whether or not there might be some malingering here and there might be some factitious disorder. So one thing to point out is that it's very difficult to make an accurate diagnosis if your clients are dishonest. So I even take that one step further and know that most clients won't really lie to you on purpose. They're not coming in with the purpose of being of misrepresenting themselves, but sometimes they just don't know what they don't know. So they might not know exactly how to accurately depict their symptoms, while they still might know that something is not quite right. So it's going to be our responsibility to ask the right questions to make sure that we're able to truly capture what's going on for them. I do want to point out some differences between malingering and factitious disorder. So when it comes to malingering, what we're talking about is an outright misrepresentation of symptoms. And this is usually with some sort of goal in mind. So I might have the goal of obtaining some sort of money, such as disability payments. There also might be some insurance compensation for me. Or I'm just trying to gain some sort of accommodations somewhere in my functionality, such as at work or at school. And I could also be trying to avoid responsibility with this. So that would be something you would want to make sure is not happening. And the only way that you can do that is by continuing to assess the client over time. And certainly, it starts to become very clear when someone is malingering. Now, factitious disorder is a little bit different. There might be some misrepresentation of symptoms, but not with a discernible reward, something that we know is they're getting out of it, such as the compensation. So for factitious disorder, this might be more along the lines of, I just need to be sick. Typically, we can link this to some other psychological situation. Factitious disorder is technically a DSM-5 diagnosis. And it is because, in a lot of times, a person that is experiencing factitious disorder is not doing so in a, what is the word I'm looking for? In a way that they are truly understanding that that's what's happening. It's more of a delusion for them. All right, so we're going to move on to the next step. Substance use. So you want to assess for substance use. And there are a few things to consider when you're doing that. One of the things is you want to see if the symptoms that are in front of you are linked to substance use of any kind. So firstly, making sure that if a person comes to you with some sort of psychosis or confusion, or even in some cases mood presentations, that's not linked to because they recently used some sort of substance. Alternatively, there could be the substance is the etiology of the mental health disorder. So a mental health disorder that's brought on by substance use, by prolonged substance use. So this could be something what people used to call wet brain. If you use alcohol for several years, eventually you do start to have cognitive decline. Part of cognitive decline can be a behavioral presentation. And so the etiology of that disorder could be because they use alcohol for so many years. In order to become aware of these types of situations, you'll want to use certain things in your assessment. So starting with interviewing patients, obviously. You'll also, while you're doing the interview, want to be checking for signs of intoxication. So are they slurring their words, excuse me? Are they slurring their words? Do they smell of alcohol? Alternatively, have they recently used, let's say, spice, and now they're experiencing hallucinations? Things like that you might look for. In addition to interviewing the patient, it would be really important to interview family members. Now, obviously, you want to interview family members as part of your assessment anyway, especially if they're available to you. But specifically speaking, when it comes to substance use, your family members are going to be able to tell you, yeah, he drank a fifth before we came in today. And also, you'll check or request medical records. So in a perfect world, when a person comes in for your intake, they will have all of these things ahead of time. So you'll already have their medical records and you'll be able to see if they've recently had some issues with substance use. If they don't come in with them, then certainly requesting their medical records can be helpful too. Here at the CSB and other CSBs, we do have the added benefit of having, all of our services right here in one EHR. And so if the client has been seen for issues before that are related to substance use, you'll have that information in their chart already. There are some ethical implications when it comes to substance use. One of the main ones being 42 CFR. Does anybody know what 42 CFR is?
No.
Okay. So 42 CFR is a release of information, and what it means is that it's very different than our normal release. Basically, what it's saying is that when someone requests information about a client, their substance use information is protected by 42 CFR. So when someone requests information, if they don't request specifically a substance use eval or their substance use history, we don't just offer that information. They have to explicitly request using a 42 CFR in order for us to provide that information. So that means that when we have some of our younger clients, some of our youth clients that come in for substance use issues, their medical records, if anyone were to request them from us, we don't automatically send that information to like a doctor or a psychiatrist or something like that. They have to request that specifically. Questions about that? Great. All right, I see there's a couple of questions in the chat. Oh, yeah, going back to what we said about why it's important. You don't want to treat the client with an issue they don't have. Absolutely. All righty, moving right along to the next step, medical conditions. So when it comes to mental health symptoms, there are some that can masquerade, if you will, as general medical conditions, and vice versa. There are certain medical conditions that can look like mental health symptoms. And so it becomes really important that we're able to discern if what's in front of us is a mental health symptom or something connected to a general medical condition. Mainly because we want to make sure that if the person in front of us is experiencing some sort of medical issue or medical emergency, that we get them to the help as soon as possible. Additionally, obviously, if someone is going through a stroke or a UTI, no amount of therapy is going to do anything about that. They need to be treated medically first. So we want to make sure, like if it's a UTI, a typical symptom of an untreated UTI is hallucinations and psychosis. So obviously, putting this person on meds for like psychosis and engaging them in some sort of cognitive restructuring therapy is not going to help them. They need to be treated for their UTI. So we want to make sure that we are making those appropriate referrals if someone in front of us is actually experiencing a general medical condition. There are also considerations for mental health disorders that are in relation to general medical conditions. For instance, in certain cases, someone that has cancer might be experiencing major depressive disorder. That's an understandable thing, but the major depressive disorder was not present prior to their diagnosis of cancer. So we want to make that distinction when we're diagnosing. Also, in the realm of medical conditions is understanding that certain medications may have psychological side effects. So certain medications may have the effect of making the client look like they're experiencing a mental health emergency or crisis, when actually it's the psychological side effects that they are experiencing from that medication. And in that case, again, we definitely want them to be treated medically and not with, ongoing medication from like a psychiatrist. Some good ways of being able to discern what you're looking at is in relation to or as a result of a general medical condition would be to assess the temporal relationship, understanding the onset of symptoms versus the onset of the general medical condition. Obviously, if we're not experiencing the symptoms until the onset of the general medical condition, there could be a relationship there. And so we want to be really careful about that. Also, you want to look for atypical patterns. So what we mean for that is, for instance, an episode of mania in an elderly person, but for the first time. So if I'm looking at someone that is 65, 70, 80, and they have never been diagnosed with bipolar disorder, and yet what's in front of me looks like mania. I would definitely want to make sure that there was no other medical condition that might not be responsible for that presentation. Alternative, something like a memory loss, but with something like mild depression. Again, we don't expect that something like mild depression would result in memory loss, but yet the two things are coinciding. So I would definitely want to make sure that I sent a client like that to their PCP and maybe even to the emergency room to make sure that there wasn't something like a stroke happening. Questions?
No, ma'am.
Great. We're moving. We're shaking. All righty. So now we have ruled out that there's any malingering happening or any factitious disorder. We have ruled out that the presentation has anything to do with substance use. And we've ruled out that the presentation has anything to do with medical conditions. And so now we are ready to finally look at what's in front of us and determine the primary disorder. Now, one thing I would say is that for me, this is where things start. And that's why I say that the whole pattern is not necessarily a step 1, step 2, step 3. Because for the most part, when a person comes into your clinic, you are going to start with this step. You're going to start with, well, what brings you in for treatment? And that's determining the primary disorder. As you are using your own decision tree, which is something we'll talk about later, you're going to be discerning, is there a malingering aspect here? You're going to be discerning if there is any sort of substance use issues. You're going to be identifying if there's any medical conditions. So that's why I say the whole process kind of takes place all at the same time. But you're likely to start with the actual symptomology that brought you in. What is happening? So in order to do that, you have to develop an understanding of groups of diagnoses. When I say groups, a good way to start or kind of conceptualize that, we know that there is a group of childhood disorders, right? So normally, childhood disorders include ADHD, oppositional defiant disorder, conduct disorder. And so we're going to start with that group and then start to ask questions that determine which way we're going next. When a client comes in and they say that they're experiencing what they think is depression, so you're going to start with mood disorders. You'll start with, okay, what makes you feel like this is depression? And ask the right questions to determine which way you're going to go. Is it going to be depression? Is it going to be another different kind of depression? Is it going to be a different kind of mood disorder? Is it going to be bipolar disorder? As part of that, you're going to be considering comorbidity. Does everybody know what comorbidity is?
Yes.
Yes.
You want? Okay. Does
Yes.
anybody want to venture out and tell the class, if you will?
Comorbidity is usually when you have a condition that is more likely to coincide with another one, increases your chances of having another diagnosis along with the one you already have or are being diagnosed with.
That is exactly right. Can anybody give me just an example of 2 diagnoses that tend to be comorbid?
Autism and ADHD.
Okay.
The
Anybody
words
else?
right out of my mouth.
Okay. Anybody else?
I think for children, one of the ones that most prevalent ones I've seen is ADHD and ODD.
Oh, yes. We definitely see those 2 together a lot.
Also, OCD is in that circle, OCD and autism. or all three,
Okay. Yep.
ADHD, and autism. Okay.
Kind of an unhappy triad, if you will.
The way I like to call the twins is depression and anxiety.
Yes, ma'am. Yes. Depression and anxiety go hand in hand. I like to say that depression is the concern about the past, and anxiety is the concern about the future. And we're missing the present.
Oh, we don't have one for that.
Well, because that's the whole point. That's the whole point of anxiety and depression, is that you're not in the present. You're either 100% concerned about the past, or you're always thinking about the future, and you're not living presently.
Mindfulness.
So when you start to consider stuff like comorbidity and groups of diagnosis, this is how you're able to start to build your own decision tree. So we're going to do a little bit of that today, a little bit later on. But you can see how you're already starting to connect certain diagnoses together. And when you have a lot of shared symptomology and presentation, it's going to be really important for you to have that working understanding of the groups of diagnoses, so that you can kind of very clearly discern where one goes. And then you have to ask the right questions. You have to be able to. Everybody seen iRobot? I love that part with the guy. It's like my responses are limited. You must ask the right questions. If you think of your clients in the same way, that can be very helpful to you, because they can only give you what they know. Now, yeah, there are going to be some clients that you have that have been in the game for so long, they know exactly what to tell you. But for the most part, you're going to have to do some digging. And so it's going to be really important that you know what are the questions to ask in order for you to arrive at the right diagnosis.
I have a question.
Yes.
Is there a visual for the decision tree?
Yeah. But we'll talk about that a little bit later.
Okay.
Any other questions before I move on? Okay. All right. So the next step is to consider adjustment disorders versus other or unspecified. So this is essentially, I have ruled out those first three, right? I've tried to come to some understanding of a primary disorder, and I'm not quite getting there. I'm getting 4 out of 5 of the symptomology, or I'm getting 3 out of 4 for the criteria, or I'm not really getting that there's any sort of, I see all the things, but I'm not seeing where they kind of stop and start. For a major depressive disorder, there is a 2-week period, but then we assume that at some point those symptoms kind of taper off and the person has a baseline. But we recognize that sometimes some people don't ever come out of the 2-week cycle. And so we have another diagnosis for that. But sometimes we have the ongoing, what appears to be depression, but we're not getting the full criteria for depression. And so what do? This is where we kind of land. So to discuss first, understanding other or unspecified. That's kind of the almost there, but not quite. We know that there's something. We know that there is obviously an impairment in the client's presentation and their functioning on a day-to-day basis, but they're not meeting full criteria. So we will want to consider an other or an unspecified. Other is more to say that we know that the criteria is there, and we know why we're not meeting criteria. Unspecified is more or less, we know that this is probably it, but we're not meeting the criteria. So you want to look at things like presentation and significant impairment and functioning to make that distinction. When it comes to adjustment disorders, this is to say that not only are they not meeting a full criteria for an actual diagnosis, we can tell that this particular symptomology is in response to some sort of psychosocial stressor. So a good example of this is a teen that moves from a place where they had lots of friends and were extremely bubbly and involved in a lot of different things, and then they move, and now they don't want to deal with anyone. They're extremely isolating. They seem to cry all the time. So they're obviously meaning some version of depression, but we know that these symptoms didn't start until they moved. So this is likely an adjustment disorder. Our adjustment disorders do have some specifiers. So there is conduct, there is mixed mood, there's anxiety. So again, just kind of making that distinction of, again, these symptoms didn't start until this particular stressor. And then I want to take that a step further to say, and their symptoms are expressly geared towards, let's say, anxiety. Or they're expressly geared toward a mixed mood. So you can make that specifier. All right. Okay. This last step honestly kind of blew me on how I make this clear in a training setting. So the way that they kind of talk about this is establishing a boundary with no mental disorder. So what they're saying is you want to know if maybe there is actually no mental health situation happening here. Perhaps they just had a bad day. Perhaps maybe the anxiety is coming expressly from SOLs. Perhaps the depression is coming from the fact that someone close to them passed away very recently. And so what we're saying here is that there could be an instance where we've arrived to this place where actually there's nothing. But part of that is understanding what baseline behaviors are in the broader sense of kind of from the general population, and then of course in the specific sense in that specific client. So understanding that there was a time when I behaved this way and now I'm behaving this way. Typically, this is assessed by saying, when did you first start to notice that this was an issue for you? So hopefully they'll give you something along the lines of, 2 years ago or last week in some cases. But helping you understand that there was a time when this was not an issue. So you want to recognize what that baseline is for them, but you also want to recognize what a baseline is for, just kind of like I said, the general population. So we can reasonably understand what a typical person might go through in certain situations, what a typical person might go through in moving versus a person that becomes extremely depressed from moving. That could be the difference in an adjustment disorder versus no mental disorder. Another way to kind of conceptualize this is impairment and functioning. So we know that there could be a presentation of symptomology, but there should also be some impairment in different settings. So I might not be sleeping, but is my not sleeping affecting how I do work at work, how much I'm staying on task? Is my not sleeping affecting, like, maybe I don't go out anymore because I'm too tired all the time? That's an impairment in functioning. Or am I telling you I don't feel like I'm getting a lot of sleep, but actually I am, and I'm totally doing fine, and I'm going to work, and I'm really just tired, like adults get tired. So kind of coming to that understanding with each person that's in front of you. So it's going to be important also to be familiar with what would be acceptable in certain settings and at certain ages. So to me, when I think about something like an ADHD, right? So most children at some point will appear to be hyper, will appear to have a lot of energy, maybe even be a little messy. Sometimes they're going to talk loud or interrupt others. And sometimes they're going to talk a little fast because they're excited. But you can reasonably expect at a certain age, a child does learn to sustain their attention for more than 15 minutes. They do learn that in certain places you have to lower your voice, like in a library or when you're in class. As they learn manners, they learn not to interrupt others. And so you can discern that at a certain age, probably somewhere between 7 and 8, a child will learn that a child that is having difficulty with something like that, is having difficulty with behaviors such as not being able to sustain their attention for longer than 5 minutes, such as often interrupting others, such as being off task more often than not, such as being forgetful. In addition to all of those things, you might also notice that they have lower grades. You might notice that they struggle to make friends. You might notice that they have trouble sleeping. And so all of those impairments take place in different settings, in a social setting, in an occupational, if you will, or school setting, and then sometimes even physical functioning. We know that sometimes it's really difficult to get a person that has ADHD to remember to take a bath. So we know that when you have those types of functional impairments, it can cause some distress. So we want to hit all of those points before we say that the person has a mental health disorder. And alternatively, we know that if we're not hitting those points, then they may not have a mental disorder. Questions about that? Okay, so that was our last step in the 6 steps for the DSM-5 differential diagnosis. Altogether, are there any questions now that you know what the DSM suggests when it comes to differential diagnosis?
No questions for me. It's quite clear.
Good.
I just got to chew on it for a while.
Okay, that's fair. All righty, so we're going to kind of change gears a little bit. We're going to talk more about the actual psychiatric interview that we partake in when we're doing an assessment. All righty, so when you are setting up your interview, how do you use this method in your psychiatric interview? You got all the steps to differential diagnosis, but how do you actually use them in the process of the interview, right? So I've said it a lot, I'll say it again, you got to ask the right question. So for me personally, I usually start with what brings you in? And then I start with my internal decision tree. Another thing to note is that essentially though, you have to remember that in this space, you are the expert of the psychiatric part. The client is the expert of themselves. And so this interview is kind of a interface between you bringing your expertise and them bringing theirs. But in order for you to get to their expertise, you have to be the expert in the room about psychiatric stuff. So it's going to be important that you figure out how to get that information out of them. A good way to doing this could be using their language. So not using all of this, like, psychological terms, what's the duration of your symptomology? Clients will look at you like, what are you saying to me? But also, it would be nice if clients came in and they were like, hey, yeah, I've been depressed for 4 months off and on. For about 2 weeks at a time, I usually feel very sad for no reason. Sometimes I just cry. Sometimes I even have difficulty concentrating. And I'm also not sleeping and eating. That would be perfect. Great. Major depressive disorder. You're good to go. Goodbye. Instead, a lot of the time it's going to look something more like, I've just been feeling out of it. Like, I just feel like I'm not myself. And sometimes I really don't want to get out of bed, even though I'm sleeping all day long. Take that information and then lead that line of questioning from there. So I'm going to say this. If I had a client in front of me and that's what they said to me, when they say something like, oh, I feel out of it, I might counter with, when you say you feel out of it, are you feeling more sad or lonely? Or is it more like you've stepped outside of your body? Because I feel out of it could be any number of things, right? So when I say, are you feeling more sad and lonely, or is it more like you stepped out of your body? Right there, I'm already starting with my decision tree. I've already started with, okay, when you say you feel out of it, that to me, it could be depression. It also could be a depersonalization or derealization or disassociation that comes from what diagnosis?
Can you repeat yourself one more time?
I said, so it could be more of a derealization, depersonalization, or disassociation that comes from what diagnosis?
That sounds like dissociative personality disorder. What?
Yeah, I was actually thinking more PTSD.
Oh, I said BPD.
That's understandable. Okay. But I like that because what that tells me is that's how your brain groups those things together. And that's why I say we have to come up with our own decision trees, because it's really going to be about how you interpret the information and thusly how you get it out of the client. So for me, I might start with a major depressive disorder and a PTSD when you say I feel out of it. But for you, you might start with the major depressive disorder and a DID, or major depressive disorder and a borderline. That's okay. The important thing is getting to the information.
What I heard when you said that was that when you look at it, you work in to out. So things that are closer to what you originally thought and work your way out.
Yeah.
What I voiced is working all the way out and coming back in closer.
That's fine, as long as you get the information. And so your decision tree might be a little different than mine. And that doesn't matter. It won't matter what the decision tree looks like. The important thing is, are you doing that internally in your brain as you're asking the question? All right. So other considerations. Sorry, question.
Just one. So just for clarification, there's no specific way to make your decision tree. There's no step by step. It's just as long as you are grouping that information and going through the process of elimination.
Essentially, yes.
Okay.
We will go over how you're going to make your decision tree a little bit later on. But yeah, it is going to be about how you discern that information. Okay. So you trying to do my decision tree may not work for you. It might, but it might not. And so that's okay. The important thing is how you arrive at the information, getting that most accurate diagnosis. Now, I'll say this. As you continue to work in that space, you might find that, oh, when I use this kind of decision tree that, let's just use Christina's way of looking at things, going out from in, it took me a lot longer. Or but also you might have found that when I did it that way, I got a lot more information than maybe I would get going from inside out. Because maybe then the client feels, they're thinking about all of the different things that that might contribute to their mental health presentation. Whereas coming from an inside out perspective kind of hones in on a very specific space. Neither thing is wrong. It's just going to be your experience of how that looks in each person. You might find that when you have one client, you do more of a specific decision tree. When you have another client, you might feel like you need to do something a little bit more broad. Neither thing is wrong, as long as you arrive at the information that you need. Other questions? Okay. All righty. So, other considerations. There's a few things that as you're developing a diagnosis, you want to be kind of cognizant of as you're going through that process, okay? When it comes to medical conditions, now, most intakes are going to ask about medical conditions at some point. Here at Western Tidewater, we use the SSPI, so we know there's a whole specific section that talks about medical conditions, that talks about the client's current medical conditions and their past medical conditions, the client's family current medical conditions and their chronic conditions from the past. So you want to be aware of during that time what those symptoms might look like that are medical issues versus what medical issues might look like mental health issues. So very similar to what we talked about in that step, whatever step that is, earlier in the 6-step process. That's when that's happening for us. Other agencies, their intakes may or may not have medical questions built there, right there in the intake. And so those people are going to have to make sure that they question that on their own, that you are bringing those things up. So it's going to be important also to have somewhat of a working knowledge about medical conditions that are commonly mistaken for mental health. And then knowing that at that point, you might have to refer the client out to a PCP to make sure you rule out that medical condition. So that's that. Moving on to cultural considerations. So this is, in a lot of ways, kind of a call to action when it comes to being aware of cultural limitations and cultural biases, especially when considering a diagnosis. A good way to conceptualize this is that previously, way back in the day, women used to be diagnosed with something that they called hysteria, or they might call them hysterical, right? We might think of this in the modern day more like a depression and or maybe even bipolar disorder. The important thing to note, though, is that just as ridiculous as it was back then for women to be considered hysterical because maybe they weren't sitting quiet and letting the men talk, if you will, sometimes some of that same stuff can show up even in 2022. For example, we know that women are statistically higher to be diagnosed with bipolar disorder, right? We know that that is a fact. When you look in your DSM, it's right there in the back when they talk about statistical implications and presentations. However, you might want to start thinking about, why is that? Is there some sort of actual biological reason why a woman might be more prone to mania than a man? Is it that women tend to be more likely viewed as manic than a man might be? Is there a role that society might play in the treatment of women that could lead to the higher rate of bipolar disorder? Or could this be a misdiagnosis issue where we're diagnosing women with bipolar disorder that don't actually have bipolar disorder? Or are men just not diagnosed enough? And maybe they should be. Now, I don't know the answers to these, and that's not really the point. The point is to consider that as you diagnose, that when the person comes in, a lot of times I've had women come into my office and tell me that they are 100% bipolar because they've been manic. But when you actually sit them down and talk about what mania looks like, they may have just been having a bad day. They may have been talking very fast, and it may have seemed like their thoughts were racing. But when you think about it, women tend to be the project managers of their homes, correct? It's not good or bad, it is what it is. But I'm not here to make a judgment about whether or not women should be project managers of their homes, or maybe there should be some sharing of that. But what I will say is that maybe that woman is so used to multitasking that her mind runs very, very quickly. And maybe to someone who comes into that situation while she's also got some other things going on, now discerns that, oh, wow, she's hyperverbal, she's labile, and now she's got bipolar disorder. Just something to consider. So it's important that you kind of have those conversations with yourselves, but also with colleagues and your supervisors when you're making those diagnoses. Someone has something to say?
Yeah. I remember a professor told me that she was a part of this experiment where they were doing evaluations on Black families or something like that. Mm-hmm. And she said that she was so nervous to say something, but the mother kept patting her head because her extensions or weave was itching. So they kept they created something saying like she had a tick or something. She was itching her scalp. And she knew she had to say something. And is that an example of what you're talking about when you say cultural considerations?
Absolutely. Absolutely. In that particular situation, we're talking about somebody, we know why she might be patting her head, because her scalp is itching. But someone was willing to say that she had a tick. That could result in like saying that she has a tic disorder. It could result in something like a Tourette's diagnosis, or even something more as serious as like a schizophrenia. And would that even really be fair to her?
No. So when we consider cultural, we don't just consider. We consider everything across the board as something as small as how, Black women typically itch their hair. Wow. Okay. That's good. It's good for me.
Absolutely. Absolutely. That's a good space to start with. Moving on to age considerations. So earlier we talked about, I mentioned something about a manic episode for someone that is maybe like 65 years old as maybe like a first episode kind of mania. And that would be a red flag. If I were to see something like that, oh, a 65-year-old came into my clinic and told me that they were bipolar because recently they had their first manic episode, that would be confusing to me. We know that bipolar disorder typically presents teens to early 20s. So for this person to be 65 and be just diagnosed with bipolar disorder says some things, and we definitely want to make sure that we're questioning that. Now, is it possible? I don't know. I think I would be interested in finding out if that person maybe likely had some presentation of manic episodes prior to 65 and had gone undiagnosed for several years. But also it could be that we're missing some information and that it's not mania at all. Could even be some sort of mental health, some sort of medical condition that's masquerading as mania. Don't know. And especially somebody that age, I will be very interested to make sure there wasn't a medical condition that was being mislabeled or misdiagnosed as bipolar disorder. Some other considerations for age might be something like ADHD, but at 2 years old. That's hard to say. How are we diagnosing that? Is a 2-year-old expected to be sustaining attention for 15, 30 minutes? I don't know. I don't think that we are expecting that. And so that would be something that we would want to definitely consider before moving forward. Looking at the time, I'm going to move on from that, but definitely something just to keep in the back of your mind. You're talking about presentation. You want to take in what's in front of you, right? So sometimes you might have like an affect incongruency. So I'm fine, but I'm crying. Or I'm not fine, but I'm laughing. Bouncing leg or eyes darting. All of this information can give us something. All of this can give us some sort of information. So are they nervous? Maybe they're agitated. Or they might even be responding to some sort of internal stimuli. In addition to that, you're also thinking, have they ever been diagnosed with schizophrenia? And if we're looking at something that's internal stimulus, like psychosis, and they haven't been diagnosed with schizophrenia, what might be the reason? Could it be that it's actually more like a schizoaffective, and this is the first time the psychosis is making its debut versus normally being more depressed? But I think the important thing here is to take in all of that information and kind of start to make sense of it. One thing that stands out to me, I worked in emergency services for about 3 years at Chesapeake. And I had a young lady come in. She was severely depressed and she had previous SI. And she was coming in because her mother-in-law had gotten some text messages from her the night before. And when they realized that she was okay in the morning, they still wanted her to get checked out. And this particular young lady came into the office, so not in any sort of medical setting. When she came in and I was doing the assessment, I started to take in the fact that she was very shifty. She seemed to be sweating and her skin was yellow. What does that tell you?
Skin.
Got some type of medical. Yeah, she jaundiced skin.
Yeah.
Liver.
Jaundiced skin. And then, you know what I asked her? Have you already done something to hurt yourself? And her answer was yes. She had taken an overdose of medicine probably 20 minutes before the police picked her up. She should have been in the hospital. And so I ended the interview, of course, right then, called 911 and got her over to Chesapeake Regional. I don't know what happened, but it was not good. I can tell you that. And I will never forget that, because if I had not taken all of that information in and had just gone with what she was telling me, which was more along the lines of, I'm not going to hurt myself now. I'm okay. But she was crying. She wasn't looking me in the eye. Like I said, she's very shifty in her eye contact. And something just told me, her skin was very yellow. And, she had been around people all morning. She'd been in our lobby. She had been with the people who brought her in. And I was the first person to ask her, have you already done something? So it's going to be really important. I can't drive that home enough to take in what's in front of you sometimes. Lastly, ethical consideration. So, yes, if it walks like a duck, talks like a duck, acts like a duck, it probably is a duck. But is labeling this person a duck ethical? Is it right? It's important to remember that diagnosing someone is serious and can make a difference in their life, good or bad. So a lot of times when diagnosing comes up, the ethical considerations are very gray. In that space, it's going to be very important that you're constantly staffing with your supervisor, staffing with your other colleagues. Don't be afraid to have the conversation because you're afraid that you might look stupid or silly or uneducated. At the end of the day, it's going to be so much more important to have that conversation about that ethical consideration than it is to not. Okay, so remember that part of it. What we're doing is very serious. We're going to report this information to their insurance companies. Insurance companies are going to make assumptions about that client based off of that diagnosis. So we want to be discerning and specific and accurate, but also don't be afraid to make the right call. I know I've had some clinicians before that have been very, very afraid of diagnosing bipolar disorder. I know I say that one a lot, but it's kind of an important one. I think that's why I bring it up a lot. Because if someone has bipolar disorder, there are a lot of implications of it going untreated. We know that untreated mania can result in psychosis, can result in delusions. And when you mixed that episode with a depressive episode, now we've got a depressed person who's also got racing thoughts and a lot of energy. And that's not a good combination. So don't be afraid to make it if that's what it is. But also you want to take into consideration all of these other things that we've already talked about today. Questions about any of that or even comments before we move on? Cool. All righty. We gotta speed this up a bit. So the DSM, the American Psychiatric Association has released a text revision of the DSM-5. It's now called the DSM-5 TR. It may be with the number 5 or it may be with the letter V. But there's some things that we want to talk about those additions. So you'll definitely want to do your own research about this and become really abreast of those new changes, but especially if you don't intend on buying the new TR, which I don't think you will really need to. If you go to the APA website, they're actually pages and pages on what the information is. So you don't really need to buy another one, but if you really are so inclined, then you absolutely can. So there's going to be some updated descriptions of the prevalence and risk and prognostic factors when it comes to each disorder based off of the new findings from research. If you go to the APA website, you can actually click on each individual group of diagnoses, like trauma-related stressors or the anxiety group or whatever, and it'll tell you what those descriptions are. There is a new disorder under the trauma and related stressors group called prolonged grief disorder, and the code is F43. If you know PTSD, PTSD's code is F43-1. So that gives you kind of an understanding of where this lies in the kind of spectrum of trauma and related disorders. There's also some change in terminology. One is from intellectual disability to intellectual developmental disorder, which I really appreciate because it's very difficult to tell people things like if they're not disabled, they are differently abled, and using that terminology when no one else does. So I'm happy about that. Conversion disorder is also now called functional neurological symptom disorder. So you want to look at that. There's a new category for other conditions that may be of clinical focus, and that is suicidal behavior and non-suicidal self-injury. So we can put that directly on the problem list now, which is exciting because that lets other professionals know right away we have someone who has had suicidal behavior in their past or who has attempted self-harm. There's also some codes for initial counter for someone with a suicidal ideation or attempt, which is a T code, subsequent encounters, which is also a T code, and in a history but not current suicidal behavior, which is a Z code. Also, there's a code for non-suicidal self-injury, R45.88, and a history but not current of NSSI as well, which is a Z code. There is a notable emphasis on language in the new TR. So they have graciously updated problematic terminology with something that's a lot more preferred. So some of the problematic terms we had before: natal sex, natal male, natal female, gender reassignment treatments, desired gender and minority. Now we're looking at more preferred terminology, birth assigned gender or individual assigned male at birth or individual assigned female at birth. And sometimes you might even see that as AMAB or AFAB, or even heard it noted as AMAB or AFAB. That's what they're talking about: assigned female at birth, assigned male at birth. Gender affirming treatments, experienced gender, and non-white instead of minority. All right, getting to prolonged grief disorder. So what's cool, I was wrong, it's F43.8, excuse me. So that gives you a little bit more information about where it is in the actual spectrum. So since the death, the person that is living, obviously, that has experienced another person dying, since that death, the development of the persistent grief response is characterized by one or both of the following symptoms, and they have to be present for most days to a clinically significant degree. So this is someone we're talking about that is not just experiencing just a typical grief. We're talking about someone that is experiencing a very intense grief that has lasted for a long time. We're talking about at least a month of more days than not of this kind of intense, severe symptomology of grief. So intense yearning and longing for the deceased person, and then also preoccupation with thoughts and memories of the deceased person. In addition to that, we also look at, is there an identity disruption? So if they say something like, oh, I feel like part of me died when they died. There could be a marked sense of disbelief about the death, avoidance of reminders that the person is dead. So maybe even in the space of not saying that they're dead, or not using was versus is. And in children and adolescents, this may be characterized by efforts to avoid reminders instead of actual avoidance of reminders, because sometimes children aren't always in control of whether or not they can avoid those reminders, but if they're trying to avoid those reminders. Intense emotional pain, anger, bitterness, or sorrow related to death, to the death, excuse me, not to death, just to that specific person. Difficulty reintegrating into other relationships and activities after the person has died. So the person no longer can engage with their friends or pursue any interests or plan for their future because they're kind of overwhelmingly focused on this person that passed away. You might even hear this say, someone might say something like, how can I engage in A, B, and C? How can I go to a comedy show? How can I, allow myself to laugh knowing that this person has died? Emotional numbness. So kind of the opposite of that extreme intense feeling, the opposite of that complete elimination of feelings of any kind as a result of the death, and then feeling that life is meaningless as a result of that death, or intense loneliness. So that's the end. That's the criteria for prolonged grief disorder. I would love to go into that more, but we are running out of time. Updated descriptions include changes in the criteria sets for following diagnoses. You can take a look at those on the APA website. All righty, getting to the homework. We're going to make our own decision tree. So we're going to do a little abbreviated version of that right now. And then I'm going to encourage you all to do it on a broader sense on your own. So in order to do that, we're going to start with a group of diagnoses. Then we're going to highlight some of their shared symptoms and presentations, or, those kind of nuancey symptoms and presentations. And then start to figure out how to eliminate a diagnosis and how you begin to consider the process of differential diagnosis. All righty. So here we have some questions you might use if you are working with someone that tells you that they're depressed. So the client comes in and they say, I'm so depressed. Now, what I would have liked to have been able to do is white out these other things so you couldn't see them. And then if you said them, then I would click them, and that would be really cool. But we don't have that technology. At least Chiquita doesn't have that kind of technology where she knows how to do that. So we have them all in here right now. But if your client comes to you and says, I'm depressed, what would be your first question? What do you want to know first, individually?
I would say, can you describe what that looks like to you?
Okay. It looks like I can't get out of bed even though I sleep all the time. Now what?
How long has this been going on?
Okay, so with that question, what are you looking for?
The duration of the
Okay,
symptoms.
what is that going to tell you?
It'll help rule out. It'll narrow down which way to go or which one to rule out in terms of depression, like major depressive disorder or.
So how long do you need to hear that I've been having this issue for you to say, okay, let me continue with depression?
6 months.
Okay,
Depressive.
so
Persistent.
let's say that. Go ahead.
No, I was saying persistent is a year, I believe, but never mind. You said let's go with that one.
All right, so I've been depressed for about 6 months. What's your next question?
I would have you describe your symptoms of what you feel depression is. Have you been sleeping? I'm sorry. Go ahead.
Okay, so it's just how I feel. I feel depressed and I can't sleep And also, I also sleep a whole lot. I don't know. It's so weird.
Do you feel
I think I
sad?
would. Oh, I'm sorry. Go ahead.
I'm sorry, Monique.
No, it's okay. I was just saying, I guess I would ask, well, when did you begin to feel this way? Because you did ask, I guess, how long, and they said 6 months, but kind of walk them back to when they started feeling that way to kind of describe what was going on in their life at that point.
Mm-hmm.
Okay. So yeah, I noticed that I was feeling this way about 6 months ago. And it just kind of fell on me, and I just really didn't even want to be around anybody.
Did anything happen at that time to make you feel sad or not want to be around anybody?
I don't think so. I mean, I really don't have a reason to feel this way. I just do.
And have you lost interest in your regular activities that you used to like to do?
Yes, I don't want to be around anybody anymore. And I used to really love crocheting, but I just don't even have the energy to do that. And I don't have the motivation.
Well, there goes 6. You lost your motivation. You having trouble sleeping. You lost your interest, trouble sleeping, isolation. You said something else. I've been counting on purpose.
Okay. Is there anything else you want to ask me, or you want to stay at 6?
Suicide risk.
I would still ask more questions to rule
Okay.
out
So Terza said,
disorders for comorbidity.
okay, perfect. Well, let's start with what Terza said. She said suicide risk. So tell me more about that. What are you going to ask me?
Have you had thoughts of harming yourself?
Sometimes I feel like it'd be better if I wasn't here, but no, I haven't ever wanted to do anything about it.
I think I will explore that a little bit more with you, just asking, what do you mean you don't want to be here?
Sometimes I feel like it would be better if I wasn't alive.
I would
I would
ask.
want to know about drug use.
I would.
Okay.
I would ask one more question with, have you ever hurt yourself? Because we asked if they're thinking about it, but we never confirmed if they ever hurt themselves.
In the past?
No, I've never hurt myself.
Okay.
Okay, we could also ask about whether or not they've received any treatment in the past or had any hospitalizations.
What is that going to help you with when it comes to diagnosis?
If they've had hospitalizations, you can find out what the hospitalization was for. If they're currently in, or if they had treatment in the past, you can see what the diagnosis was then, what they were being treated for.
No, I've never been in the hospital. No, I've never been treated before.
Do you take
Go ahead, Christina.
Do you take any medications that may change your mood?
No.
Okay.
I would ask, have you been depressed for 6 months straight, or were there any moments where you felt like doing something that you lost interest in?
That's a good question. So let's say, no, it's not 6 months straight. It's off and on.
So then we would start getting really specific. So in a week,
How long
would you say you feel depressed out of 7 days?
I was gonna start there, but everybody kept talking, so I didn't have a chance to jump in. I've been trying to unmute myself, but everybody kept going.
Just stay unmuted, Nicole. Stay unmuted.
I'm gonna stop sharing the screen so we can see each other.
Okay, a long time ago, I was going to ask. Let me turn my camera on. There we go. I was going to ask, does this, because I thought 6 months was a long time, it needed to be broke up, because there could be 3 or 4 days where the individual feels fine. They feel like they're feeling fine.
Mhm.
But it's more often than not. And then I was going to also ask, how does their symptoms affect their functioning? Like, does it cause you to disregard your personal hygiene, your dental hygiene? Does it affect your work schedule? Does it affect if you're a parent, you're parenting? Does it affect any other relationship in your life at all, where you're not showing up in all of those other roles in your life as well? Now I can mute myself again.
Don't mute, stay unmuted.
I like what she said, because we never asked the question about
Yes,
if you
experiencing some
recently.
issues with when I don't want to get out of bed, I don't want to take a shower, but I still go to work. I still show up for my kids.
Okay. Now, how do you show up?
By doing what they need me to do.
Okay. So this is this little gray area that I feel like I may trip up on, because there is such a thing as a functional depressant individual.
Mhm.
And so while they can answer, oh, well, I go to work and I get my work done, and I take a shower. But example, a response that would let me know that I could still possibly be looking at major depressive disorder, but as soon as the weekend comes and I no longer have any obligations, I am not showering, I don't get out of bed, and I order pizza to make sure the kids eat.
Let me pause you there and say that firstly, so we have arrived at our symptomology for depressive disorder. And now we're talking about functional limitations and that sort of thing, because that's also a part of our diagnosis. But we're also getting to a space of specifiers now. Are we talking about mild? Are we talking about moderate? Are we talking about severe? That's why I asked the pointed question of, oh, do you want to stop at 6? Because that's going to be the difference on what my specifier is.
We didn't ask if you had any recent children, if you recently given birth.
That would make a difference in the depression. Nice.
Tell me why. Tell me why that makes a distinction.
Postpartum,
yeah.
Okay, so what if I was depressed before from the kids, though?
You
Before
could
you had
have
children?
postpartum.
I would ask if you noticed that, if it was because you're female presenting and identify as female, if it was sometimes always around the time of your menstrual cycle starting.
That's a good question. What is that?
Because there is a diagnosis, I don't know the exact.
It's premenstrual disorder.
Thank you. There we go. I knew it was in my head, but I didn't have the right order of the words.
Yeah.
Yes.
Okay. So I want to take a step from this. So we have gone very deep into depression. And I know that there was a point where Christina had talked about comorbidity.
Yes.
What happens next with that? How do we get to that space?
We need to start asking more questions that kind of lean away from depression and start talking about what happens with comorbidity. And so since we know that depression also goes hand in hand with anxiety, we need to start targeting questions that focus on anxiety, like the racing thoughts.
So here's a good. So to me, just to give you guys a little bit of insight and to save us time, there is a symptom that is shared between depression and anxiety.
I wrote this down. I'm sorry, I forgot I was still unmuted. I'm sorry.
Excuse me while I pull out my purple book.
One time. It's difficulty concentrating.
Okay.
And I was waiting for one of you to give me that. But that's okay. Fine.
Okay.
So yeah, difficulty concentrating. So I'm going to ask, do you have difficulty concentrating? If I get a yes, then I start down that road. I might start down that road because comorbidity, right? So even if they say no, I'm totally fine with my concentration. I still might ask, what's another question for anxiety?
Right, because their description of concentrating may not be as labeled by the DSM-5. It may not be
so you're
functional. So when you're asking, do you have difficulty concentrating? And they say, no, I don't. I would follow up. Can you tell me what your concentration looks like? Are you able to complete all of your work tasks on time, or, things of that nature? Do you stop and start different tasks? Because they can say they can concentrate, but if they're concentrating on TV, well, insight to where their concentration is. It's not, it's easier to focus on things that have no meat and potatoes.
Okay, so let's say I say something along the lines of, yes, it's very difficult for me to concentrate, especially when I'm depressed. What's your next question? What else do you need to know for anxiety? That's where we're headed, right?
Right.
Not just Christina, anybody.
You were asked about any excessive worrying.
Mm-hmm.
Oh yeah, I worry all the time. I think my job is definitely going to fire me one day, because I'm always tired and I just don't even want to do anything.
Are your thoughts always racing?
No, not always.
How often would you say your thoughts race?
They probably race at least once a day, but just not all day or once a day. Not all day.
Okay.
What about, do you ever have palpitations or heart acceleration?
Exactly. Physical presentations of anxiety. Sometimes my heart races.
Sometimes your heart races. Do you ever feel like you're going crazy or losing control?
No.
What about a fear of dying?
Yeah, but it's weird because I also feel like it would be okay if I died.
Yeah, depression.
Okay.
I got to go back and check how many we're checking off for anxiety. And then we would have to know how long that's going on. So we would have to start talking about duration.
Anxiety, you need 3 or more symptoms.
And how many have I given you?
Yeah,
3 or more.
Okay. So now what happens? What else do you need to know for your diagnosis of anxiety?
Duration.
Well, you talked about that you were worried that your job would fire you. Is your work performance lacking? Have you
I think it is. I feel like I'm just the bottom of the barrel.
Have your supervisor had any meetings with you in reference to your work ethic, your work performance, or anything like that? Or is this something that you believe yourself?
No, they never said that. In fact, the other day I got Employee of the Month.
That is the worrying out of proportion to the event.
I would
I
move for duration to
Okay.
see when it started. So can you remember a time when you knew the excessive worrying started?
Can I hop in before that question?
You sure can.
Before the duration, I would ask if the racing thoughts or the excessive worrying was only attributed to work, or was it across any other domain as well, like anything else?
Very nice.
Yes, I always worry that my kids are going to get hit by a car randomly.
Okay. So would you say that you focus on things that are out of your control more often than not?
Yeah, because I can't control them.
Have you ever had an incident or seen somebody get into an accident?
It's a good question, but no.
Okay. You said
And
it.
why was you asking that?
PTSD to rule it out.
Mm-hmm.
So that was good. So you see how you kind of go from the next one to the next one to the next one. We were going to do another thing, but we're not going to do that. Instead, we're going to talk about the homework. Now, for Region 5, when you guys are using this for an actual training, you'll have groups of trainings. And so you'll want to bring to your training group your own decision tree for childhood disorders. What does that look like for you? Where do you start with, and how do you kind of discern if we're looking at an ADHD, if we're looking at oppositional defiant disorder, if we're looking at conduct disorder? What things in your homework, and when you bring it to the group, I want to know what things did you share with your others, and what are some other areas you didn't cover or chose to place elsewhere. So what things didn't you share with between ADHD and ODD, and why not? Or what things didn't you share between ODD and conduct disorder, and why not? And what are some areas you didn't cover and chose to place elsewhere? So perhaps you chose to place disruptive mood dysregulation disorder in another space. Why would you choose that? And what could you gain from that?
I'm very
Also, I want to point out, really quickly, as far as resources for helping you to discern a differential diagnosis, there is a DSM-5 handbook of differential diagnosis that is available on Amazon. There's also a handbook that is, it says, I think it's like Handbook Speedy Study Guides that's can be helpful to you as far as learning how to differential diagnosis. Also, there's the DSM-5 overview, which is a quick study academic. It's a pamphlet looking thing that you can also order any of these from Amazon. And obviously the DSM-5 full 5th edition.